Hmm. That's the Shinola Hotel.
Yeah, so actually my penthouse is bigger than my apartment.
Oh my God.
So I have like a huge like rooftop balcony that like wraps around a corner and a 2,000 square foot hotel room.
This
Yeah,
is
it's one bedroom, two bath.
this is the top of the Shinola. Is that what it is?
Yeah. So like that's Tiger Stadium
Oh, that's pretty nice.
and that's
Oh,
whatever building behind me. Yeah, it's a little sweaty outside though. I might go inside.
I could probably wave to you. I live
Okay,
right across from it.
Oh, I'm on the other side. You could wave to Jess though. Jess's penthouse is on that side of the building.
everyone has.
Yes. But actually the inside's pretty nice too.
Oh,
And
yeah.
like it goes all the way back. There's like a whole hallway thing.
I always like the decor of the Shinola. It's kind of this, what was it, like a mid-century modern kind of thing. I don't know what to call this.
No, I agree. I like the vibe is awesome. I like the style. I like the art. After I stayed here, I tried to be able to buy these paintings, but you can't find them.
Hey, CC, did you see my patient today?
I did. I was going to text you. Yeah, I saw her. She's like 2030 or 2040.
Yes.
Yeah. Yeah, I tried to tell her, hey, let's go in, get that blood out of the bottom. She just doesn't want to do it.
Okay. Did you put some laser in, or am I going to put the? Okay.
She's seeing you next week. Yeah, she's seeing you next week.
Okay. All right.
I think you could put plenty. I think the blood is actually just on the bottom one quadrant.
Okay. Okay. Very good. Thanks for seeing her. So she didn't want to play right now, right?
She's on the fence. I told her, because with all that anesthesia issue, I told her if we need to do it, we could maybe propofol her. I can do the whole thing in like 10-15 minutes, but
Yep.
we can propofol her. So she's kind of semi-willing to do that.
Okay. We'll see what happens. Thanks for seeing her.
Yep. So do the fellows know if Dr. Abrams or
Dr. Abrams is coming. He was just doing the teaching session.
Oh, okay. Oh, that's on the different side.
Yes.
Okay. I wonder if he assumes it's on the same Zoom, because it used to be.
It's just waiting.
Yeah, just waiting.
And then is Chapman and Yoga Nathan in town today?
Chapman knew about it. I think he's going to be joining. We're in the OR together today.
How many cases did you guys have? Because it started off at 7 when you,
so he had so many, and then they said it's too many. And then of course, like last day, a lot of people canceled. Classic. Today, someone didn't have a ride. So we ended up having 3. One was pretty long.
Okay.
Yeah. What?
Yeah, because we were talking about it at the beginning of the week. They're like, there's like 7 cases.
Yeah. They sent me an email. They're like, too many cases. You have to cancel. So I moved some. And then yesterday, 2 people canceled. It's just classic. And then today, 1 person canceled. So
okay.
3.
So could you have a case, and then you also have some cases Yoga Nathan wanted to present too?
Yeah, they're just pictures, really.
Okay, no, that's fine. That's fine, because I think Caesar doesn't have like a real good TRD or anything yet.
Yeah.
So we figure we'll just have Brett and you show the cases, and we can just talk about things.
I have a clinical kind of dilemma if we have some time afterwards.
Well, then let's do that. Then we'll each do one, and then afterwards, Jim, we can do the
it's just quick photos to spark some discussion. So
sure. Well, okay, Dr. Abrams is here. Brett, maybe you can start.
Sure, I'll kick it off. Oh, I need to host. I need the power.
Oh, that's right. Sorry.
All right, can everybody see?
Yes.
Got it.
All right. All right, so this is a case I did with Dr. Chapman, actually a couple months ago, maybe actually last month. Couple of good learning points, couple of mistakes I made along the way. So this was a gentleman who I saw on 7/14. He has a history of diabetes, PDR. He had a little bit of a mild TRD in that right eye with a non-clearing vitreous hemorrhage. So he went for a PPV, kind of a light PPV, light membrane peel, lost a follow-up, and then came back with worsening vision in the right eye. Hand motion, pressures are okay, no APD. So originally, this is kind of where he started. This is way back in March before his first surgery. So they really weren't too aggressive on the first surgery, just, you know, tiny membrane peel, cleared up the blood, didn't look too bad, put in a lot of good laser. And then he came back and had aggressively proliferated in the course of 3 months. And now comes back with a TRD.
This is post one vitrectomy.
Post one vitrectomy, 1 month after vitrectomy. Yeah, so comes back aggressively, had proliferated with TRD, RRD combined, and use macula off. So before I start the video, I know we always talk about, you know, aggressive proliferation, the diabetics, but this seemed pretty aggressive for a 1 month interval. I know maybe there have been, you know, a tiny, you know, perivascular micro break just from, you know, pulling on the hyaloid in these diabetics of the original PPV. But Dr. Lin, Dr. Abrams, Dr. Chapman, have you seen patients kind of aggressively proliferate like this over the course of a month after surgery?
Yes.
Okay.
You know, were you able to totally get the hyaloid up?
I was not involved in the first surgery. I'm not 100% sure, but when we went back for the second surgery, I think there were still pieces of the hyaloid that were down. And as you watch the surgical video, it does seem like there are pieces of the hyaloid that are still down.
Yeah.
So I was involved in the first surgery. And this is, I guess, this is kind of what we wanted to talk about afterwards. So it's a good introduction. So with these patients who are young diabetics who have non-clearing vitreous hemorrhages, where we go in and we try to clear the hemorrhage, and, you know, they may have some membranes and hyaloid down, but we kind of weigh the option between being really aggressive with the membrane peeling versus like just clearing the vitreous and putting down laser. And if their retina seems intact and they have no break, I just heard so many different thoughts on that. Some folks think that if you're really aggressive, you'll make a break and things, you know, you'll end up in a bad situation, and you may be able to get away with like being not as aggressive, putting in good laser, and then going from there. But it seems like with these really young folks, this happens. And so that's kind of what we wanted to talk about afterwards, like Dr. Yoganathan and
I think there's a difference between leaving parts or even whole membranes versus leaving the hyaloid down.
Okay.
Even if you're going to section membranes and leave membranes, you need to divide the membranes. They need to be sectioned up anyway.
Okay.
And you section it, if you got membranes and you're really worried about getting breaks, and you feel like that you can release traction in these eyes adequately, then you'll leave those membranes, but you'll section them so they're not going to contract and create problems. And then you isolate those membranes.
Okay.
You isolate them by separating the vitreous. And the vitreous is going to be, as long as the vitreous is still down, if these membranes contract further, they're going to exert additional traction.
Okay.
So you like to separate the vitreous. You may section the membranes, and leave even significant parts of membranes, but you still need to get the hyaloid up.
Okay.
So you want to make sure that hyaloid's separated.
Okay.
So I think that's critical in the diabetic, is separating the hyaloid.
Okay.
But
So
even if you've made the decision, you're just going to section membranes and leave membranes there. Which is okay. I mean, that's a good technique. People have been doing it since the 70s successfully. But even in those cases, you need to get the hyaloid up.
Okay.
So the hyaloid will be up every place except where you've trimmed it. You've separated it around these membranes, but you've trimmed it back to the membrane, but the hyaloid's up. So I think if the hyaloid's still down, there's a much greater risk of them developing a recurrent, progressive fibrosis and recurrent traction detachment.
Okay.
Dr. Abrams, so when you're talking about hyaloid in the setting of diabetes, I think it's not quite the same as a RRD, in the sense that the hyaloid, unless you pull on the, at least on the nerve, unless you pull all that membrane off, it's kind of still more so the hyaloid. I think, do you mean the hyaloid that's attached to the outer side of the membrane of the posterior plaque, in the sense that kind of that AP hyaloid?
Well, I mean,
inside
where the membranes are, the vitreous is attached to the membranes.
Right.
When you get away from the membrane, the vitreous is attached to the retina.
Mm-hmm.
Right.
And according to multiple authors, one of the biggest risks of failure of diabetic vitrectomy are in eyes. If you're looking at an eye and the risk for failure before you do the surgery, one of the greatest risks is an eye that the hyaloid is everywhere attached.
Yeah.
It's attached to the membranes, but it's also attached to the retina. Okay. What you really need to do is get where it's not attached to the membrane, you want to separate it from the retina. Okay. And then where it's attached to the membrane, you want to isolate it. You want to cut it and free it from the membranes. So if you've sectioned the membrane, if you're using an en bloc type, or you're using a small gauge cutter and you're going to remove the whole membrane, you're going to remove the hyaloid and the membrane. If you're doing a sectioning technique, you're going to try to separate the hyaloid around these membranes. You're going to isolate the membrane by cutting the vitreous all around the membrane, separating it all around the membrane, cutting it, and then you section the membrane to release the tangential traction. So, I think that's one of the important parts of diabetic vitrectomy is getting your hyaloid out.
One of the things that I think the easier configuration is the hyaloid that's outside of your membrane, more peripheral to your membrane, peripheral to the arcades is separated, where you can just, either turn your cutter down and then you can start eating around it. The more difficult ones is outside of that, your membrane is actually still down, still firmly adherent to the retina. In those cases, I think the plane is your membrane is contiguous kind of with your hyaloid plane going outwards. And then inside your membrane, it's generally, or, in the fovea, in the macula, there's another layer. So frequently you'll look at this plaque and you think you can just go in your cutter from top down and get under the plaque, but you can't. It just keeps pushing the plaque down. So frequently in the macula, you need to open up a space in your hyaloid, either with something sharp or with a forceps or something. You need to get into that plane before you start going into your plaques. Otherwise, you just can't get under your plaque. You'll just push things down.
Yeah, I agree. I fully agree with you, CC. Steve Charles has, and I agree with him, has always made the point that you need to dissect these things inside out.
Yeah.
And so you start at the posterior pole and you go outward. And often if you've got this eye that's got this, massive contraction of these membranes along the disc and the arcades where everything's tangentially contracted, but the hyaloid is basically down everywhere. What you need to do is usually you're going to find a place that you can, OCT will sometimes help you. You can find a place where you've got a little bit of a separation. usually it's adjacent to a membrane, and you can guide it. Sometimes you can use a sharp blade, just a sharp tip blade, and go in and make a little opening in the posterior hyaloid. It's usually developing a little bit of fibrosis in that area. So it's usually under traction, under tension. And you can usually find a place where it's very slightly separated. You can make a little opening in it, and then it'll separate from the macula. You can usually just either a pick or something like that, or the tip of your scissors, and you can just gently pull it off the macular area. Then you have access to get under the membranes that are on and adjacent to the disc and along the arcades. But you have to get under the hyaloid and the macular area first before you can dissect those membranes.
Gary, I agree with all that. And removing the hyaloid in some diabetics, especially young diabetics like this, can be unusually difficult, almost approaching PVR in some cases. And so I tend to, try to get it off with the triamcinolone. Throughout the case, the middle of the case, I'm still hunting for hyaloid, and I'm hunting for hyaloid at the end. And in this case, I wonder if it's really sort of you think it came up with a vitreoschisis and so forth, but I think Chinwe is going to present a case for a patient that was unusually difficult as well this evening, and just trying to find those planes or some other techniques for getting that off. And I think we'll cover that in a little bit.
Yeah, the vitreoschisis is notorious. I feel like in diabetes, I feel like it's always split. Even in the ones where you think you got the hyaloid, you have a nice, plane outside of the outside of your plaque, kind of this so-called AP traction sort of thing that you cut it, and it seems like all you have is the isolated plaque. If you go underneath that area, because when I do it, I always have my ILM forceps or my end grasping forceps, and I'm always exploring the hyaloid or exploring the ILM. So frequently you're gonna find a split hyaloid.
Often, like we were saying, you have to get an opening in the hyaloid before you can get at these membranes around the disc and the arcades. But as you go into the periphery, one of the areas, you'll see areas of often fibrosis along a vessel, or you'll see an area of plaque of neovascularization, fibrous plaque of neovascularization along a vessel, maybe nasal or superior, someplace outside the posterior pole. And when we used to use scissors for all of our dissection, you'd go in there and you'd try to free this up and section it initially with scissors. And what you'd find is you'd find the edge of the hyaloid there, and often then that's where you would start separating the vitreous. And then once you got it started, it would start separating, and you could pretty much go all the way around and get it separated. But I agree, it's sometimes extremely difficult especially if they've had a heavy panretinal photocoagulation already. Sometimes it's pretty hard to get it off, but usually you can if you just now using a small gauge cutter, the way we isolate all the membranes with that and remove the membranes, you'll find the same thing. You're cutting, around this area, this plaque of neovascularization or fibrous neovascularization, and you'll find the edge of the hyaloid, and you can start lifting it, and it'll go from there. But it's just something, just like Chris said, you've got to just keep throughout the case. You've got to be working on it and trying to make sure that you get it separated.
And the thing, unlike inducing a PVD on your normal, you can't just catch the hyaloid and just start pulling, kind of thing. You actually have to cut into it. You have to actually use your cutter to sometimes you want to do radial patterns of cutting into the hyaloid. You'll have patches of hyaloid that's much more stiff, especially if there's NV going into the hyaloid.
Every place you've got NVE, it's going to be tacked down.
Yeah.
And often they've got a lot of areas of NVE. little areas that are fibrous, but it's holding it's got the hyaloid tacked down in that area pretty tightly. And you can't, all you can do is try to separate around the areas of NVE. And, but you like to isolate those areas of NVE by cutting all the hyaloid around it.
Yeah, that's a good point, because last week, Dr. Lynn and I were doing a case on like a very mild diabetic with vitreous hemorrhage. And I was making sure to lift the hyaloid, and I was inducing a PVD, and I thought I could very gently work it out into the periphery. And I caught a tiny patch of NV that I didn't really see and created a super tiny slip break. Patient ultimately did fine, just lasered the crap out of it. But yeah, learned that lesson last week as well.
Well, that's, once again, if you separate the hyaloid there, if you relieve the traction, that's no great disaster. Those will do fine.
Yeah, he's doing, we honestly just put in an air bubble and lasered it, and he looks great.
If I have a choice between leaving the hyaloid down and creating a break, I'll create a break. I'm not going to, you don't want to leave the hyaloid down in diabetics, because it's just you're asking for trouble.
That's a really good thought. It really drives the point home. So obviously macula detached. Let me show the video here. So just as we're starting, just kind of exploring any residual AP traction, kind of just seeing what vitreous is left, putting some Kenalog in the eye to highlight what is left. Again, trying to get any, create a little snowstorm, try to get any AP traction that may be residually left that's lifting up this posterior pole. But there wasn't that much AP traction left, maybe a little bit inferiorly. And then kind of just exploring the hyaloid above the retina, what's going to catch, what areas are going to catch. So what I know to come back to once I start peeling. And now we switch to a macular lens, and I use a combination of Tawari T2 forceps and 27 gauge dissection. This case did take I think the patient did ultimately have a good outcome. The patient case did take a very long time. So one of the things in the future that I would have liked to have done is switch to bimanual. I did not use bimanual for this surgery, and I think it would have helped speed up the case a lot. So I keep switching between my Tawaris and my 27 gauge cutter. Basically, I create a little space with the Tawaris, and then I eat that space up with the cutter. Create a little space with the Tawari, eat that space up with the cutter. My goal is just to constantly be creating a little space for my cutter. And so I kind of just keep lifting, wiggle a little right to left, lift, wiggle a little right to left. Just try to keep creating space so then I can use my cutter and dissect and eat the membranes. So we continue to dissect. One thing I also learned in this case, this patient did not get a pre-op avastin. So bleeding was something that dealt with throughout this case. The patient continued to have very sticky heme accumulation. And like each time it was almost like peeling fibrous membranes again. Which was incredibly annoying, and I think also prolonged the case.
Brooks McEwen, who used to be at Duke, he'd remark that you do the case and then you do it again.
Yeah, I felt like I peeled the inferior or the superior arcade 3 times.
Yeah, and
each time it was sticky. I felt like I was worried if I was going to pull too hard on the blood, I was going to create a break.
Well, you can. The clotted blood can be so adherent. Where you've got irregular retina.
Yeah.
It's sort of denuded retina where you've removed those membranes. This clotted blood can be so adherent to the retina that when you pull it off, you can actually tear the retina.
I'm glad I feel vindicated on that now, because this case was actually particularly one of the worst ones I ever had. I don't show it as much throughout the video, but at least 3 times I had to come back and peel the arcades again, as if I had peeled them originally. So I think pre-op avastin would have been a good choice in this patient, and a good learning point for me.
In the old days, when we were using 20 gauge, we had the tissue manipulator that had diathermy on it. And so the moment we'd see a bleeder, where we were, the tissue manipulator, you would inject fluid through it and it'd blow the blood away, and then you could see where it's bleeding from, and you could focally coagulate the bleeder. I absolutely love the tissue manipulator. You could keep control of the eye, the hemorrhage very, very well with it. It used to be one of my favorite instruments.
That's a cool tool.
Yeah, I think the two greatest instruments ever invented were the MPCs and the 3-function manipulator, right, Gary?
Absolutely. I love those instruments. I absolutely loved them.
You could do what you do with the chandelier and just stick a diathermy in your second hand. Sometimes in very vascular areas, you sometimes do that. You just diathermy and then cut. I mean, that's the closest thing we can come to that.
A little closer, yeah. At the end of this, I do diathermy everything at the end of this case. I always try to go a little lighter on the diathermy and the diabetics. I try not to go overboard. But now we got everything off the nerve and the superior arcades. I'm starting to work a little bit into the nasal periphery. He almost has these fixed folds that the hyaloid is created when it's contracted. So just working into these fixed folds. And here we go again, peeling the heme again. Trying to be very careful because the retina is really moving underneath it, as you can see in this video.
Sometimes when while you're in the plane, you kind of don't want to lose the moment and start diathermizing, but especially if you're in the middle of a plaque and the blood bleeds into this kind of half-worked plaque, it can be very adherent and you can't just pull it off. If your blood is just bleeding onto like some smooth retina, yeah, it'll just come off as a whole piece. So usually, especially if I'm working on a very vascular plaque, at least I try to stop it.
So I did
at the time.
So that's a really good point. So here I end up doing diathermy later, but not after creating multiple headaches for myself throughout the process. And like Dr. Lynn was saying, Dr. Abrams, I actually couldn't peel it. I know the video kind of went through it quickly, but I had to put my cutter in and cut the blood as if I was cutting membranes again. Because I felt like I was putting too much traction trying to peel it and the retina was just moving too much. And I didn't feel safe.
Was the
and then
pretty much all down on this one?
Yeah,
that's what it looked like.
At least, definitely nasally. Didn't look like there was that much hyaloid over the fovea, but definitely nasally. There was a lot of hyaloid. Oh, whoops, sorry. I keep somewhere around here. So now I finally diathermy the bleeders. Try to do light diathermy in the diabetics. Don't want to go overboard. And then again, just kind of running my cutter down the folds just to make sure none of the folds are fixed and nothing's hiding in there. And now that we switch back to the full view, get rid of the macular lens, you can see the retina is pretty mobile. There's only the one break superiorly. So I put in a little PFO just to see kind of how things are gonna relax out. And I also kind of use the PFO to squeegee out a little bit of the subretinal fluid. So I want to make the retina a little less bullous. So I drain a little bit of fluid and kind of try to use the PFO to squeegee out. It's a small hole, so it didn't work incredibly well, but there was a thought that was in the back of my head. So kind of roll it.
In the diabetics, I'd be a little cautious with PFO. Frequently, your breaks are posterior, and you end up just pushing the fluid anterior, and then when you take it down, it just all comes back.
Okay. And so, and that's a really good point. I didn't put a lot of PFO in the eye. I only put in actually that small bubble to the level of the break because the break was pretty posterior. I kind of just ended up using it as like a third hand to help drain the anterior fluid to keep the macula flat to try and prevent like reaccumulation of fluid in the macula. So then fluid air exchange. As I take down the PFO bubble a little bit, and then he's flat 360, looks pretty good under air. So do good 360 endo laser. And then, wait your 10 minutes, repeat drainage just to make sure. And then ultimately he looked, because I don't have a post-op photo, so we'll just appreciate this one picture right here. that he looks pretty good. Everything's flat. All the traction seems to be relieved, resting nicely. And then unfortunately, he hasn't gotten his photos yet. I think he's coming back next week for a photo. But Dr. Chapman saw him personally, I think, just about a week ago. Still hand motion, still has a decent gas bubble in the eye, but everything is flat. No rebleeding, good laser, no fluids accumulated inferiorly as the gas is going away. So hopefully he'll do okay. He actually needs, unfortunately, he needs a fit probably in the other eye, which is his better eye. But he's starting to pull up his macula. Young guy. But
that brings up a good point when you have the decision tree in terms of when you have one eye, the fovea is still attached, but you know, you have a TRD that's fovea sparing, and you have some vitreous hemorrhage. When do you decide to do the surgery? Typically, you know, a lot of times, if they have a vitreous hemorrhage in the middle, it makes it a lot easier. The vision's already down. You can clear the vitreous hemorrhage, and frequently the fibrosis isn't as bad at that point. You can a lot of times clear it all out, and they'll do well. The problem is when the same scenario and they don't have a bleed and their vision is like 20/25. Those are the harder ones to decide. Generally, what we've done is we monitor those closely, and if the fovea doesn't come off, we don't typically operate on it. And you'll see they can have a fovea sparing TRD for a long time without actually progressing onto the fovea.
I couldn't agree with you more.
and then so overall, he did well. Hopefully he'll continue to do well as the gas clears. A couple of important things I learned: pre-op Avastin would have been probably helpful to help control that bleeding, which gave me such a pain in the butt the whole case. But you know, he looked okay at the end with a little diathermy, and then probably quicker to go to a chandelier. Just would have sped things up. Otherwise, I'm just taking instruments in and out of the eye. Create space and then cut, create space and then cut. Whereas in actuality, I could be doing those two things at the same time rather than just wasting time.
There's a learning curve to the chandelier in the sense that, you know, it's whatever you do the best. But the chandelier does require a lot of that left-handed manipulation of tissues. And sometimes you know, during the learning curve of the chandelier, you can end up making breaks or causing more trouble with the chandelier. I mean, I like chandelier because the main thing is I could put loose retina under tension, or I could put membranes under tension, and with either a forceps and a scissor or forceps and a cutter, that when you put them under tension frequently, you end up making a lot less breaks.
Oh,
But
the reason it's hard to learn to do bimanual surgery with a chandelier is that when you're working with two instruments, the eye wants to move and tort at the, where it's going through the sclera. So you've got that area, and then you're working directly on the tissue. So as you're working on the tissue, if you move those instruments, like that, you tort the eye and move the eye. So the eye will, you'll think you're getting ready to do something, and you'll tort the eye, just by moving the instrument. And, you can put excess, traction on your tissue, or else, it'll just move out of your field. So, the learning curve is learning how to keep, not move the eye where the eye is, where the instruments are going through the sclera, and, keep them very still, but be able to adequately do what you need to do with the forceps and scissors and so forth, at the tips of the instruments without moving the eye around. So it took me a while to get where I could actually do that. Initially, it was a very foreign thing to do. It seemed like such a great idea, but the doing it is actually not the easiest thing in the world.
And one thing with the chandelier that we don't talk about too much is how you place the light for the chandelier. typically we like to put it at 12 o'clock. 12 o'clock with a single light source is for diabetic vitrectomy, at least it will cover basically everywhere you need to see without shadowing yourself. But what I typically do is I put whether I'm doing a 25 gauge, 27 gauge chandelier, I put my port for the chandelier in there, and then I put my light pipe. I put the tape on the light pipe, I don't tape it down. And then I flip my biome. And then basically you hold the tape very gently adjacent to your light and until you adjust the light to your position, and then you tape it down right there. You don't want to hold the chandelier down, tape it, and then let go because it will bounce into a different spot. You'll think you're shining at one place, and then once you let go of your finger, it bounces somewhere else.
Yeah, I think before I pull out the chandelier, I think Brett did it for the first time that I saw, and we talked about it, and Chinwei did it today, was to get everything you can with a 75 in these bad cases. You may show this case, it's a future from today, Chinwei, but was getting everything with the 25, but you could really put the 27 gauge through the 25 and allowed her to get under and segment more and delaminate with having to go to the chandelier. So it took longer, but the other thing with the chandelier is I almost never just put one in. I mean, the resident or the is there or somebody to assist to move it around, much as they would scleral depressed. But I don't tape the steri strap down firm. I just put it down to hold it, and you can pull it in and out a little bit. But it's difficult in any case. I agree.
Do y'all use a lot of 27s for your diabetics? 27 gauges?
I've been using a handful of 27. Like Dr. Chapman said, we did it today. I've done it with Dr. Yoganathan. It's nice. It allows for dissection even more so.
I find with the 27 is it's too sharp. It pokes into the retina as often as it gets under the plane. I find getting under the plane, even with the 23, I think you can get into most planes. The key is actually to find the plane first, in the sense that a lot of times you start from basically the inside, the center out, and you're not being able to get under the membrane. A lot of times it's not because your cutter's too big. It's because there's the hyaloid is actually, you're actually on top of the clear part of the hyaloid that you're just pushing everything down. And so usually if you start from the macula with something sharp like a pick, you can use a forceps and you open the hyaloid face, and then you follow that. Generally speaking, you can get into the plaque 23, 25, 27, between 25 and 27, I didn't feel a huge advantage. What ends up happening is sometimes in the more ischemic retina, it's easy with the smaller gauge to poke through the retina. All right, we want to go to the next case. Well, Caesar, why don't you do yours, and then because Chinwei has a couple to follow.
Sure. Yeah, let me pull it up. So this is just a discussion on what different attendings would do in this case that we have going forward. Which is a little bit of a complicated diabetic case, a lot of social factors that play into it. So this is a 31-year-old woman, uncontrolled diabetes type 1, PDR-OU, had a TRD in the right eye, and then a recent vitrectomy with the TRD repair in the left eye, had C3F8, membrane PO endolaser, that was then complicated by MRSA endophthalmitis, had orbital cellulitis, and then had vitrectomy 2 times with intravitreal antibiotics, spank and ceftazidime. Currently NLP in that left eye, some monocular. She also is very sick systemically, has hypertension that was uncontrolled, and she needed to be admitted for that, has anemia of chronic disease. Her hemoglobin dropped to 6 during a hospitalization, pulmonary embolus, and DVTs. So
other
she had
than
been
that,
seen
she was okay.
other than that, doing okay, yeah. So she originally presented in 2019, was found to have PDR in both eyes, lost to follow-up before getting any treatment. In May 4, 2021, she came back. Here's some Optos photos of both eyes. You can see she has vitreous hemorrhage in both eyes, some dehemoglobinized in the right, has NVD, some fibrovascular membranes, severe attenuation of the vessels, and a similar picture in the left eye with some pre-retinal heme temporally, a little bit more fibrovascular membranes over the macula, causing a little bit of traction. At this time, she was 2200 in the right eye and 2080 in the left eye. Here's an OCT of that time back in May. In the right eye, a lot of vitreous debris, but her macula is flat, no DME. In the left eye, she has a little bit of vitreous debris, but there's that tractional membrane that you can see just nasal to the fovea pulling up on the retina. So we have photos when she returned briefly in June. Her vitreous hemorrhage is worse in both eyes. Unfortunately, I don't have a vision from this time. You can see definitely worsening, progressing of her disease. So brief course.
Did she get any laser?
She had a little bit of laser inferotemporally in the left eye from the previous Optos, but really not much. She didn't come for many sessions, really just once. So on July 30th, 2021, that's when she underwent the vitrectomy with the TRD repair and her better seeing eye, which was 2080 around that time. She missed her post-op day 1 appointment, unfortunately. And on post-op day 2, presented with a hypopion without vitritis on B scan. At that time, it was thought to be most likely sterile inflammation. She was treated with topical steroids and periocular subtenons, Kenalog. Then she missed post-op day 3, presented on post-op day 4 to the ED, not the clinic, complaining of severe eye pain, found to have high pressures, had an AC tap that was also sent off for culture. And at that time, she was admitted to the hospital for uncontrolled systemic hypertension to 180s to 200s. And that was on August 2nd. On August the 4th, sorry, that was actually on August the 3rd.
Cesar, was she have any pain when she presented on post-op day 2?
Yes, at that time she did. She did. She had decreased vision and pain.
Yeah,
I believe she was in motion.
Pain would have told you it was not a sterile endophthalmitis. The sterile endophthalmitises typically don't have pain.
Mhm.
So, I mean, should have tapped and injected at that point.
She came to the clinic. She was transferred from the hospital on August 4th. At that time, she had a very tight orbit, very tense lids. She had decreased extraocular movements, -3 in all directions, consistent with orbital cyclitis. Her hypopion was worse, and she was NLP at this time. So we took her urgently to the OR, did a vitrectomy, AC washout with diluted betadine, intravitreal antibiotics, and filled her with gas again. The vitrectomy yielded a sample that was positive for MRSA, and the AC tap that had been done several days prior was also positive for MRSA. So she was, since she was admitted, we started her on IV antibiotics and IV methylpred while oculoplastics was following. Over the course of several days, her orbital cellulitis improved, her movements improved, pain improved, but it did look like she had persistent inflammation and persistent fibrin that was slightly worsening with some inferotemporal scleral thinning. So she was taken back for repeat vitrectomy on 8/13, and since then has been slowly improving. So we saw her again in the clinic on 8/24. She was discharged from the hospital on 8/23. At this time, she's hand motioning the right eye, NLP in the left eye still, APD by reverse. Her pressures are 19 and 17. And during that hospital stay, she became more systemically sick. Her hemoglobin dropped to 6. They did a full GI workup. Looked like it's just related to her ESRD, but overall, a very sick young woman. This is just some of her exam of the left eye, very chemotic conj, superiorly worse than inferiorly. Had some inferotemporal subconj white debris that was likely the STK that she had, with some scleral thinning behind it, but no prolapsing of uveal tissue. Diffuse edema on the cornea with the endothelium being coated by this dense fibrin debris in the AC, and had some sutures that with the knots buried. She also had a large abrasion during her hospital course that was slowly improving on topical antibiotics, now much smaller, 2x1. And the iris was barely visible nasally in that left eye, but appeared normal. There was no view to the back when we saw her in clinic. In the left eye and in the right eye, you could just see some dense dehemoglobinized heme. This is the Optos photo, but clinically it looked to be mostly dehemoglobinized without any view. Here's some B scans that we were able to obtain when we saw her in clinic. This is of the right eye, which is now her better seeing eye. There's the PVD with some tractional membranes attaching to the nerve. And then temporally, there is a bit of traction on the macula. At the bottom right, there is a little bit of elevation, what appears to be the retina. So it does look like she has a TRD now of the right eye involving the macula. This is a B scan of the left eye. Retina actually looks attached, but she's got thickened choroid and sclera. So in summary, this is her 31-year-old woman, diabetic type 1, multiple medical comorbidities. She's now monocular, NLP in the left eye. There's a very complicated social situation. She missed several appointments, has very poor follow-up. After discharge from the hospital, it doesn't appear that she received any home care assistance that we requested of the medical team. She just has a nurse coming in to give her IV antibiotics, but really not much more to help with the rest of her systemic care or her eye care. She's going to be coming back for a repeat visit in about a week and a half. But at this time, we're planning surgery for the right eye with a vitrectomy, TRD repair for her non-clearing vit heme and TRD. But just general questions for the audience. In a situation such as this, where she just had a devastating complication of the left eye, and going forward, we know she has poor follow-up and may not come to her post-op day 1 visits or further visits. She doesn't have home care as of this time, so it's tough for her to take care of herself, and she does have several children. How quickly are you to operate on this eye that's now hand motion in this monocular patient with the social situation? And if you are to go in, how aggressive are you in your dissection of the membranes, potentially causing breaks and maybe leading her to have further surgeries down the road if she redetaches?
Caesar, thanks. Hi, it's Deepa. Chinwe made a couple comments to me in clinic the other day where she felt there could be some additional issues going on. Chinwe, can you sort of elaborate a little bit on that?
I don't really know which comments, but she just, I guess she has very poor follow-up. And
but you said when I said something about, the reason for her lack of follow-up, at first we thought, oh, there's no one taking care of her and no one that could bring her, but her fiance was there and quite, seemed to be quite involved.
yeah, I think that her fiance is involved. I think she doesn't like to ask people for help. I think she also doesn't like to come in all of the time. I think that she doesn't like to come to the hospital. She feels like she can be okay at home. She has a father, she has a fiance. She says she doesn't like to depend on people. She said that her relationship is not a storybook relationship. So I don't know what that means per se, but I think that in general, like even it sounds like the kidney doctors wanted her to come back and to talk about dialysis, and she did not. So it sounds like she just doesn't have the best insight in general, and doesn't really, she kind of follows up sporadically for care.
I just I have a comment about this, and I've been in a similar situation, and in another situation with a patient who was markedly immunocompromised, and one got endophthalmitis about 20 years ago, and I operated on a lot of patients with cancer back east, and I think in this situation that if she loses the other eye, her life will spiral. So at some point, somebody will have to pull the trigger, but I would strongly recommend the use of intravitreal antibiotics with vanco and ceftazidime at the end of any vitrectomy for her. It has benefits that outweigh the very, very remote risks. So it's one consideration if she does go to the OR for the fellow eye, if you end up operating on it.
It's possible she's colonized with MRSA, just in general.
Yeah.
You know, is her hemoglobin still low?
Yeah, it's still chronically low. She's now hanging around 6 to 7.
That's a huge risk factor for failure if that hemoglobin's down around 6 or 7. You know, they really with that low a hemoglobin, their oxygenation is just so decreased that that's a huge risk factor for failure.
So Caesar, I think her hemoglobin was supposed to be followed up on, I think, next week, if we could keep on that a little bit to see what the follow-up is, because that's true. Dr. Abrams brings up a good point. Since the right eye has been declining, sort of steadily, if we need to delay it by a couple of weeks, I don't think it's going to make much of a difference in her outcome.
No, it won't.
Right. I don't think typically the goal for transfusion in most patients who don't have cardiac issues is to be above 7. So if she's below 7, they'll probably transfuse her, but I can't see her being actively treated for hemoglobin at around 7. So I think that may continue to be an issue for her healing and going forward for any surgeries.
You know, the last question about extensive segmentation delamination in a case such as this versus more conservative approach. Like in that first case we were discussing, you better separate the hyaloid. Don't be so conservative that you end up with a situation like the first case. Do what needs to be done. Get in there and do what needs to be done. If anything, I almost became more aggressive. The bigger the risk, the bigger the problem, the more aggressive I'd become almost. There is the occasional case where you can just go in and do a little segmentation, relieve things, and everything just does great. But sometimes it's hard to predict who that's going to be. I'd say more often it ends up like that first case where you try to do just a little bit and you realize that you should have done a lot more, and you end up with a worse situation than you started out with. When it reads.
So Gary, does this protocol change at all with age? Like these 20-year-olds?
Not in my book.
Okay.
Yeah, it's
I'm going to go back to the point about the infection, and CC makes a great point about the normal flora that she needs Hibiclens or betadine wash, maybe even drops and intravitreal. The segmentation and delamination is not going to matter if that happens again. So
absolutely.
But the protocol for MRSA colonization is not much. You know what I mean? Like, so anything that we would do would be experimental if we're going to put betadine on. Is that what you're suggesting? Betadine on the inside of the eye?
No, I'd say you could give her polytrim for a week and then betadine scrubs to the face and the eyelids like we used to do in the old days.
Oh, I I see what you're saying.
And give vanco and ceftazidime without hesitation at the end of the case.
That's a great idea.
You know, the thing with this predictability that Dr. Abrams says, that it's unpredictable. If your hyaloid is down and some of these diabetic, yes, some of them actually will do, actually many of them will be okay, but you just can't.
But you don't know.
Yeah, you can't, there's no way to predict which one's going to contract. And then if they fail, they're always the same failure pattern. The mid-periphery contracts up. Or if your hyaloid is completely down, then it'll be kind of everything's contracted.
Anyway, I think you can expect anything that can go wrong in this patient is going to go wrong. I would expect that.
Will she allow you?
Hoping not this time.
Will she allow you to operate on the right eye? Because
She's the one who brought it up.
Oh, okay, okay, good, good. I mean, there'll be sometimes occasional patients that you sometimes choose which eye to do, and sometimes you want to do the worst eye first, and then if it ends up with a bad outcome, they don't want to do the good eye, and then until the good eye ends up severe, you know, that you can't salvage.
This isn't such a good eye. I mean, this one's hand motion.
Yeah.
She's blind. She's completely blind right now.
I don't think she has great insight as far as like surgery and how sick her eyes are and how extensive her retinopathy is. So I think she feels that if she has surgery, she'll be seeing 20/20. So I think that's something that she probably should understand.
Yeah, we talked about it very extensively. I referred her already to Henry Ford, Dr. Mogg Center for the Blind. I told her that she should apply for disability based on vision. So I did sort of prep her that this is long-term and we're just basically trying to save the globe, you know, itself and just stabilize that eye.
I probably wouldn't wait too long to operate on this right eye also, because I think not too long ago, she still has reasonable vision on this side.
Yeah, she was 2200 4 months ago. Thank you, everybody. Good thoughts.
Thank you. Caesar, do you mind writing an addendum to her note to sort of outline this plan about the lid scrubs and all that? Because if her surgery gets bumped, then maybe the instructions are not going to end up translating, you know?
Sure. Yeah, will do.
All right, who's next?
Jimmy.
Let me share my screen.
Hey everyone, I just wanted to hop in really quick before Chinwe started and say, unfortunately, I have to sign off or I think Jess may kill me. I have to start helping with the mudding stuff. But thank you everybody, and I will see you all next week.
Good luck.
Congratulations.
Have a good wedding.
Thank you guys. Thank you guys. We'll see you all next week. Take care.
Okay.
Okay, so can everyone see my screen?
Yep.
Okay, so we have a 47-year-old female who presents as a new patient. She has a history of several years of uncontrolled type 2 diabetes. She has really never had much care for her eyes. She complains of several months of decreased vision. Her vision is 2100 in the right eye, 2400 in the left. And an examination of the left eye reveals macula involving TRD. So we begin with our core vitrectomy. Just working to release AP traction. Continued vitrectomy.
Is the hyaloid separating in that area?
She has pockets of subhyaloid hemorrhage throughout the posterior pole, and so it is separating in various areas. Yeah, so several pockets of the subhyaloid hemorrhage. And stained with Kenalog to see what residual vitreous we had and kind of give us some guidance. Now cleaning the vitreous up over the posterior pole and macula.
Is that subretinal hemorrhage in the?
It's subhyaloid. That was a question that we had. We were concerned about that, but it was subhyaloid. I just did decide to put in a chandelier. I've used a chandelier a few times. All of the points that everyone made earlier, I've, learned either the hard way, especially directing the light is something that, initially I had to play with. Sam taught me that I could just look and directly visualize where the light pipe was before I taped the light pipe down, like we were saying before, and not taping it tightly so that we can move it around. So now put on a contact lens and continued dissection with bimanual dissection, inside out approach. And so like Dr. Abrams was saying, when you do bimanual, sometimes, you have to kind of study the eye and try to get it so that your eye's not tilting and your eye staying steady.
So the difficulty you're having right here is the posterior heme that's still on subhyaloid. Is that what it is? The one on the macula?
Yeah,
so the hyaloid plane is still down. So that's why sometimes if you use some sharp instrument over here,
okay,
kind of area, yeah, I think that's the hyaloid. So that layer is contiguous with your membrane.
All of this.
If you lift that one up, and then you'll get underneath your membrane layer, or your plaque layer.
Yeah, that's often the first thing that you want to do is use that sharp tip instrument to kind of lift and get through the hyaloid there, and then it'll give you the beautiful access to the membranes.
Yeah, it'll just be contiguous, and then you'll just start cutting right through the.
Yeah. I ended up using a pick to kind of break the interface.
Yeah,
it's here, but. I used the curved scissors like Cece was mentioning earlier to help dissect and to cut the pegs of the membranes. Nice instrument for dissection. Dr. Lynn, is that something that you use regularly, the curved scissors?
Yeah, what you can do is you kind of grab onto, open your curved scissors, get underneath it and kind of push down a little bit and then come back a little bit. You don't want to cut it. You don't want to push down and cut because sometimes you'll include a little chunk of retina That's part of the peg, but then you push down and then you pull up to the membrane side and then you cut. Usually you'll separate the peg.
Okay.
So Chinwe, why don't we talk a little bit about, choice of using just the 27 gauge cutter versus bimanual or including bimanual, and then versus, which instruments, and, here, whether it's max grips or something more pointed. Why don't we talk a little bit about that?
So we're talking about using a 27 gauge cutter to help with dissection. And Dr. Chapman is, he's a big fan of it. And he showed it, he's something that I've done with him and I've done with you as well. Dr. Lin was saying that he feels like the 27 gauge is too sharp, and that he feels that especially with the ischemic retina, there's a risk of creating tears and breaks in the retina. As far as bimanual,
does that mean you also shy away of using the 25 gauge as a dissection tool, or you're more comfortable with the 25 gauge?
23, 25, 20. I think that the key is if you can get into that hyaloid plane, it doesn't matter as much how small. Probably 25. I find 25, frankly, to be a pretty good balance of bluntness and in terms of, I actually, I tried some 27. It doesn't add too much more to my 25 in terms of getting, if I can't get into it with the 25, most likely it's because I'm going into the wrong plane rather than because the gauge of the instrumentation. Now, sometimes you can have the peg can be a little bit really adherent. A lot of times I just end up using neither 25 or 27 can get in. I just end up using scissors for some of those areas. But usually in between the pegs, you always have space in these membranes. Sometimes it's not a visible space, but with 23, in fact, a lot of times with 23, you can get the in-between peg space. You should be able to get into it with 23, 25, 27, all three of them.
Like
the feature I like of both the 25 and 27 is that flat, that slanted back, the beveled,
you
beveled, the new cutters, which is really nice.
Yeah, that seems to it's a good, I like my 25 more as a blunt instrument. And you see me do this thing where I don't even activate the cutter. I use the cutter mouth as like a little semi-sharp blunt instrument, almost like a lighted pick or like a pick. I use the mouth itself as like a little semi-sharp blunt dissector.
As far as the bimanual, I mean, like Dr. Abrams said, it definitely does. There's definitely a huge learning curve with it. I like being able to have the traction and lift membranes up. It helps me kind of have more space. And so in areas where I'm not sure of where the plane is or where the space is, I find that pulling and holding traction on the membrane helps me advance an instrument underneath it.
Somehow, I don't know why it does this, but in bimanual, when you grab a tissue and you cut it with a cutter, it's a lot easier to go sideways, to progress sideways rather than going forward with it when you have it under tension.
Like sideways into the
yeah. So usually, if you grab a membrane and your cutter mouth is like that, you're going forward. Like this, when you're in it, you go sideways. It cuts sideways a lot easier. Like you pull for one, you pull back, and you cut that way, sideways. For some reason, in bimanual, it just slides a lot easier. A lot of times, you'll just slide right through the whole membrane.
So I end up putting PFC in as well to once again stabilize the posterior pole and act like a third hand. Then put laser in underneath. Under the PSC, nasally, despite like peeling the membranes and exploring the retinal surface. The nasal retina still just would not lay down. There was a lot of intrinsic foreshortening of the area. So we decided to create a retinectomy to allow the retina to lay down there. Is that something, I know that often patients with advanced PVR, that's something that you may find. Is that something that you've seen with diabetics or?
Well,
that tissue peripherally is non-perfused. It doesn't bleed when you cut it. It had hyaloid on it. You couldn't peel anything off of it, and it's dead white and not even bleeding. And you had already spent probably 3 hours trying to get the vitreous and the hyaloid off. So I think it was the only way you were going to get that retina attached. It was more like a PVR case than a diabetic case.
Yeah, sometimes once the break starts happening, it becomes a lot easier to make new breaks, and they start getting bigger and bigger. The part of it is the retina is like suddenly loose in that area. It's a lot easier. When there's mostly no breaks, you're a lot easier to get your instrument underneath the plaque, but on top of the retina. Once you start having breaks in that vicinity, frequently you'll accidentally go in the wrong plane, start eating retina.
Well, we intentionally made the retinectomy because the nasal area is just very contracted there. So it's a relaxing retinectomy there. And because of the retinectomy, I did put the patient under oil. My initial plan was to put the patient under gas, but because of that retinectomy, it went with oil. Dr. Abrams, would you still have done gas?
Yeah, if you do, I think with this bigger retinectomy, you'll have to use oil, but it's going to proliferate like absolute crazy. You're going to have massive fibrosis around that retinectomy.
Okay.
That it's funny, the diabetics, they tend to do pretty well with large breaks, but especially large breaks in gas, they tend to do reasonably well. With retinectomies and oil in diabetics, you get this massive fibrosis. So I wouldn't expect, I don't know, it'd be interesting to see how this has turned out, but I wouldn't expect I expect you got a lot of fibrosis.
Okay.
Back to this PFO point, I actually don't use PFO much for diabetic. I think I used it the first time like this month. Dr. Abrams, do you use it more for diabetics?
Rarely. Because usually the breaks are posterior.
Yeah, you end up trapping fluid inside the retina once you start putting PFO in. And you'll push fluid forward and it'll look flat. And then when you take the PFO out, it just comes back.
I mean, sometimes, if you use PFO and the fluid all goes anteriorly, you can make a little retinectomy, small retinectomy, a little hole, and then just aspirate that fluid out. Or allow you to put in the perfluorocarbon all the way up anteriorly, and it'll flatten the retina out. So that's, if I was going to use it, that's probably what I do, because that would allow you. In fact, I've done that before, where I'll just make a little retinectomy. I'd probably, if I could avoid the retinectomy, I would. I'd more likely do a buckle to try to support things and not do a relaxing retinectomy on this primary case. Because the fibrosis they get is just so massive that they rarely do well with these big retinectomies in diabetics. They just rarely do well.
The other thing I've done with these nasal detachment, a big plaque of nasal plaque like that, is I try to separate it as far out as I can, and there's a whole bunch that's stuck. I just separate the hyaloids that's around it, and then just leave it, laser it down, and just leave it.
Yeah.
And that's done okay too.
And these were where you've still got this peripheral traction, put a buckle around them, and that'll help sometimes relieve the traction. Then you can cut the hyaloid back all around that, at least posterior to the buckle. Then you can support it sometimes enough that you'll be okay.
What ends up happening if you just leave it completely alone and just let it come all the way to the nerve is it ends up dragging your macula towards your nerve. Say everything else you got off and then you just leave it all the way attached to the nerve. Things start getting dragged nasally. Your macula starts getting dragged nasally. I've done where I just peel the ILM off the macula and the macula seems to be okay.
I mean, it looks to me like a beautiful job on getting this wolf jaw proliferation off the posterior pole. I mean, that looks like that's really, so you ran into most of your trouble in the periphery.
Mm-hmm. Nasally, yeah.
Yeah. Sometimes you just can't avoid it. If you can avoid it, if you have to have some peripheral larger breaks without the retinectomy, sometimes you can get away with it if you can catch part of it with relieve part of the traction with a buckle. Then you're probably going to get less massive fibrosis that way.
Would you remove the oil? Like, would you go in and remove the oil earlier and maybe like plan for a buckle and plan to avoid the fibrosis and the proliferation?
I'm not sure at this point, you can do that, I think.
Okay.
How long is this patient out now from surgery?
A week.
Only a week?
Mm-hmm.
Probably still looks good.
Mm-hmm.
That's the beauty of oil, is they look so good initially post-op. It's exhilarating how good they look in the first week or two, and then that's before they go to where fibrosis starts.
No, these diabetic, like if you have a localized peripheral nasal kind of detachment or a fibrotic plaque like that, I have done it, just trim it down as close, dissect as much as you can. And if like the majority of your retina is okay, I laser around that area and laser over that area. It seems it'll contract in that area, but it seems to spare your macula at least.
Do you put a buckle? Do you put a buckle around that kind of case, CC?
It depends on what the detachment. I mean, if it's just like fibrosis and it's like a low lying thing, and I could separate the traction applying to the rest of the retina. I try to basically just separate it so that it's like a one quadrant or like a 1/5 of the total retina or less. And then I just laser it and it seemed to do okay. That local area will contract, but if it's like,
I think with the newer instruments, everybody's going after everything in the anterior periphery, but it wasn't that long ago that I agree with Gary, putting on a buckle would be an equal, if not better choice. But I think in some of these, you could probably even get away with a nice 42 band that's broad. But, I think we got out there and started making breaks because we were going after every piece of hyaloid. But if the patient doesn't get fibrosis, they could do well. So.
Because I was just thinking, what's the worst case scenario if you don't make a break and you have a plaque that's like localized less than 1 quadrant nasally? It'll cause a TRD locally, but will it really hurt the rest of the retina that much?
Well, I think if there's no breaks and you've isolated it, gotten the vitreous around it, you'd probably be okay.
Yeah, that's been my strategy for some of these, like where fovea is good and it's just a nasal detachment or nasal detachment with a vitreous hemorrhage with good fovea, that I try to not make a nasal break and then just kind of make it as small as I can and then just do good laser. And they seem to, they have contraction in that area, but the rest of the retina is fine.
Chinwei, you have photos of 2 other cases, right?
So we actually had an extensive discussion. So Brett actually presented a re-op. So it's the same patient. So because I've heard in lectures, and of course, like, I mean, I feel like the basics of diabetic retinopathy is remove the hyaloid, remove the hyaloid, remove the hyaloid. I feel like I've heard also in different lectures and sometimes get mixed information. I don't remember who was lecturing, I was watching, but anyway, and sometimes folks talk about being conservative if you have not made a break and just, but I mean, now, I think that I've learned that even if there's no break, you want to be as aggressive as possible. So that's what, so actually that was Brett's case.
Well, in Retina Connect last year,
Mhm.
Maria Baracol.
Yes, that's the case.
She presented this case that it was an only eye.
Yes, monocular. And she said she just relieved.
She went in and all she did was section to relieve the macula,
Yes.
and she went home.
Yes.
And, I think in a case like that, it's reasonable, but
You're playing Russian roulette, kind of.
Okay.
I don't think you can predict which ones will contract.
So I think that's the case exactly. And so she said that she was very aggressive in the other eye, and he ended up losing the eye. She said,
what this case of Maria's though was an end-stage fibrosis. There was no active disease.
okay.
Your case here, you had active disease. You had hemorrhage around those membranes. You had active disease here. Hers was a completely burned out old fibrotic case. And so she just went in, relieved enough traction just to keep the macula flat, and that was it. And you can do it on that kind of case, but if you got any active fibrosis, there's a fair good chance it's going to, do like that first case, you're going to end up with the fibrosis and the traction and, worse than you started out with.
Okay.
So, I think on that case, like Maria's, it was a reasonable approach to do that. But I think if you've got active disease, you have to be more aggressive.
Okay.
Gary, so we're talking about the possibility, let's say we're in a situation where there's no holes. We go inside, we're relieving the traction. Yes, of course, there's a chance that the residual vitreous and membranes can contract, but isn't that a slow process? Like, what if we watch them? What if we brought them in for optos every week, let's say, and we just kept on them? And if we started to see fibrosis, then we would intervene. Like my inside feeling is that 2 smaller surgeries is better than 1 big aggressive surgery if it's something preventable, or sorry, if it's something detectable.
I certainly don't have the answer to that. I wish I did, but
we just have such great technology for monitoring everyone.
My approach was always to, especially if there's any active disease, just try to just do what needs to be done and relieve the traction. And, most of those will do well, but every once in a while you'll get one, that just goes to hell on you. And, that's what's going to, some of the diabetics are going to go to hell no matter what you do.
What about vitreous hemorrhage without TRD? The hyaloid, how do you treat the hyaloid? Same way, or you clear the vitreous hemorrhage, everything looks good. Do you go down and try to induce PVD?
So that was the case. Like, so they're vitreous hemorrhages without TRDs, without any breaks. That's what like the original case. So that's what I was talking about anyway.
No,
Do the rules change?
The thing, I mean, most of the time, the vitreous hemorrhage, they hemorrhage because they're having a PVD.
Yeah, usually you'll find an area where the vitreous is coming up, and then you can go from there, and it'll just sort of separate out in the periphery, and then you can trim everything back and you know, you're fine. You know, I have had those where you get a break and you have to put in gas, but they tend to do pretty well.
Yeah, so that's what I was talking about. Not patients who have TRDs. I mean, I definitely understand that you have to get all of the hyaloid off for that, but I was talking about non-clearing vitreous hemorrhages and approaching the hyaloid in those cases. But it seems like I think in the future I still will be very aggressive even in non-clearing vitreous hemorrhages. Is that what everyone does? It sounds like.
I mean, most of the non-clearing vitreous hemorrhage, yeah, right? Like they're having a PVD in the sense that, I mean, I don't necessarily, unless it's clear that the hyaloid is completely down on the non-clearing vitreous hemorrhage, I don't go like stent catalog and go to the nerve and try to pull another PVD like your detachment or, you know, your macular cases. And I think I just kind of clear the, most of the time you can tell that the hyaloid is up. There may be some areas where the hyaloid is stuck to an ND somewhere that you can either try to dissect around it or you can clear the hyaloid around it.
And so in those cases, if the hyaloid is down and the patient's not having a PVD, then you'll be aggressive with that, with the hyaloid for the non-clearing vitreous.
They did not have a PVD, then I don't know. Actually, Dr. Abrams said they did not have a PVD, a pure vitreous hemorrhage. How do you, you know, you clear the vitreous, but you can tell like there's little chunks of blood stuck everywhere, more posterior. Like,
Yeah, I tried it every place that I could easily separate it. I would get it going, and then usually it'll sort of follow the other areas. You know, if I can separate the hyaloid, I'm going to separate the hyaloid.
Okay.
You know, I don't want to fall into the trap. You know, you can get trapped both ways. You can get trapped by doing too much, but you can also get trapped by doing too little. Where you're so afraid of making a break that you don't do what you need to do. So, you know, both are an error. It's an error to do too much, and it's an error to do too little. So, you know, figuring out how to split the middle is what we all have to do on every case. And these are making that decision is really hard, I think. But by and large, I always erred toward trying to get the hyaloid up.
Okay. Even in non-clearing vitreous hemorrhages.
Even in non-clearing vitreous hemorrhages.
Okay.
And you know, and I know you look at the results of the cases with non-clearing vitreous hemorrhages, they were always really good. In fact, you know, we looked at one large series where we looked at the status of the macula, and I think we had maybe, you know, out of, we had 60 or 50, 60 cases, something like that. And of the cases where the macula was not detached, all of them ended up doing okay. And the failures, the ones that really went to crap, were the ones who had the macula detached with more extensive broad fibrosis. Those are the ones that did so badly. So the non-clearing vitreous hemorrhages are just already in a group that, you know, if you just follow, they're going to do well. And, you know, I think your goal ought to be to separate the hyaloid. I mean, you got to, you know, don't be so aggressive that you're tearing everything up. But, you know, sometimes, you know, if you just try to isolate areas that are still a problem, you know, get the vitreous up enough that you can isolate the area by getting the vitreous off around it. That's all you need to do, and you're in great shape.
what do you have there, Chinwei?
It's the same case.
Oh, that was the first
same one. Yeah, it's the same one.
Then that was before Brett's case.
Yeah, this was before Brett's case. Yeah.
Oh yeah, the hyaloid is stuck down.
Yeah.
Yeah.
these look like there's not that much fibrosis, but these are really tough cases, actually.
There's always more than you think there's going to be.
Highlights a lot. Even though like you have a big wolf jaw kind of thing, those are, and a lot of blood, those are frequently a lot easier than these.
Right.
All right, well, it's 7 o'clock. I think our next month, well, Chinwei, you'll have a whole bunch of those in Dominican too.
Oh, okay, good. Can't wait.
So,
I was going to say, you know,
Peeling highlights away.
I appreciate the fellows presenting their toughest cases. It takes a lot of courage to do this. And, you know, it's a bit of a morbidity conference, but it's at least it's not a mortality conference. So, you know, stay in the saddle and stay strong. 'Cause we've all
I
been
think
there.
I think I always learn a lot more from bad cases than watching a bunch of good cases.
Well, these,
Yeah, I learned a lot.
these were exceedingly difficult cases. Exceedingly difficult. So,
That's a Kresge special.
Mhm.
So I think our next surgical conference is September 23rd, and it'll be on PVR.
Okay, great.
that'll be a good one. That's great. So,
Okay.
Right. Well,
you ought to get Dan Apple to join. He's sure doing a lot of PVR.
yeah. Seems like all the PVR in that practice goes to him.
They do. They're sending him all the cases. So,
I told Chris Adams that would happen to him too, and that's what's happening in Long Island.
that's what's happened.
So get ready.
All right. Well, thanks everyone for joining.
Yeah, good job. Good job.
Good job, everyone.
So, good night.
Good night.
Good night.
And I think, thank you.
Thanks, everyone.